So risk factors for head and neck cancer, obviously tobacco. And I put here tobacco use because people say, oh, I don't smoke. Do you chew tobacco? Yes, I do. It's still very serious risk factor because especially with chewing tobacco, what they do, they put something in there which cuts our mucosa, so nicotine can be absorbed faster, so we can get a kick out of it faster. So, and this cutting of the mucosa damages to the point of developing cancer kind of down the road. And I'll show you a picture of it. So alcohol use, very serious. Alcohol, some people would say, increase the risk of head and neck cancer by 2.2 folds. Some people would say it increases the risk of head and neck cancer up to 10 folds. And if you combine alcohol and tobacco, for example, tobacco increases by 10 folds and alcohol increases by 10 folds. But if you combine drinking and smoking, it increases the risk of cancer by 40 folds. It's not just 10 plus 10, it's magnified. So sun exposure, previous cancers, definitely if you had a history of cancer, even a small one in the skin somewhere, or if somebody in your family, direct family member had a history of cancer, it's something to watch out. You have to be extra good to avoid something like that in the future. Radiation exposure, at some point of last century, people used radiation for acne, for recurrent tonsillitis, and that was proven or it was linked to certain head and neck cancers that people started developing in the future. If you have a history of radiation for acne or for tonsillitis, it's better to kind of mention it to your primary care physician or to your dentist or maxillofacial surgeon or your ENT, so you are checked out a little bit more thorough than on a regular basis. And more thorough meaning not just look in the mouth, but feel the floor of your mouth, feel the base of tongue, feel the tonsils with a finger, or maybe using a fiber optic scope to go in the nose and look into nasopharynx. That's where nasopharyngeal carcinomas happen pretty often. Exposure of wood dust, heavy metals, leatherwork, wood dust. I love to work with wood, and apparently it was strongly linked to adenocarcinomas. It's a minor salivary gland tumor of the sinuses. When we work with the wood and we breathe everything, dust kind of lands in our nose, and that's what causes cancers in the nose. As well as heavy metals, nickel was linked to, especially nickel was linked to cancers in the larynx and in the sinuses. And leatherwork, it's pretty widespread here. So people have to know that leatherwork was also linked to adenocarcinomas of the sinuses. So recently, well, it's relatively recently, several years ago, human papillomavirus was linked to head and neck cancers. It used to be a major cause of malignancies in women, cervical cancer. But then we started getting more and more people and younger people, because usually head and neck cancer, it's 50, 60 years old. That's the demographics. But we started getting 40 years old, 30 years old people coming to us. Well, I have a and we diagnose them with the base of tongue cancer, tonsillar cancer. And do you smoke? No. Do you drink? No. And we couldn't find common risk factors for that. And researchers started looking into that issue. And the so-called genetic marker, so-called P16, was isolated. And in certain squamous cell carcinomas, so-called non-keratinizing, 95% of chances that it's caused by HPV virus. There is a direct link. So especially population from 70s, that's what usually papers say. Those people are higher risk for HPV virus transmission and contamination. Because virus, it's, as soon as we get it, we cannot get rid of it. It sits in there. And I mentioned that usually it happens in tonsils and base of tongue. That's oropharyngeal cancer is strongly linked to have an HPV as a major cause of non-keratinizing squamous cell carcinoma. because our tonsils and base of tongue full of lymphoid tissue, and that's where the virus lives. That's where it sits, in cryptic areas, because you know our tonsils, they're kind of a bunch of folds in there, and it sits in there, and at some point it can create some badness. So these are kind of classic examples of oral cavity cancers. This one, lateral oral tongue, that's the most common location of the cancer on our oral tongue. Usually it's on the side. It's really rare right on the back of the tongue when you stick your tongue out right in the middle. It's almost never there. It's possible, but in 98 to 99% of cases, that's where it's going to be, on the side. And usually a little bit to the back, closer to the tonsil. That's the classic location of the tongue cancer. Flow of mouth cancer, you can see on the picture on the left, it's tongue elevated, and you can see all this whitish area, irregular mucosa. It's relatively common presentation of flow of mouth cancer. But if we're talking about oral cavity, lip is the most common location of cancer. So flow of mouth cancer was strongly linked to alcohol and tobacco. Occasionally you can find some HPV or human papillomavirus involvement there, but most commonly it's alcohol, tobacco. If we're talking about treatment of oral cavity cancer, I found the tendency in this area here, people usually go, oh, chemoradiation, because everybody's afraid of surgery. But unfortunately, it was proven that for oral cavity, surgery is a primary modality. Chemoradiation has lower effectiveness, low rate of local control, and more chances of recurrence of it. So usually surgery is a primary modality with possible radiation afterwards. So that's another example, and that's well, on the top picture, that's exactly what I was talking about, kind of to the back on the side of the tongue. So picture in the left lower corner. It's not a cancer, it's called leukoplakia. I'm not really sure if it's okay to see with these lights, but it's sort of like a whitish changes to the mucosa. That's exactly where people usually put tobacco, you know, right here, or under the lip right here, or under the tongue occasionally, and it's kind of whitish changes to the mucosa. It's called leukoplakia. It's a precancerous lesion. Chances for this lesion to go into the cancer state is between 10 to 15%. So it's considered to be significant. So usually when people come to us saying, well, I have something white, do you chew tobacco? Yes, you have to stop chewing tobacco. No, I'm not going to do that. Well, it's kind of difficult to have to find a solution to that problem in this case. You have to stop the insulting agent to try to get rid of this leukoplakia. And usually we wait about 1 to 2 months, and if this whitish stuff does not go away, it's recommended to take it out. Because again, 10 to 15% of chances this thing turn into cancer. And while it is at this state, it's really easy to take it out, and healing process is not really terrible, and post-surgical changes most like close to none. So oropharynx, basically 1% of all new malignancies in the United States is oropharynx. That's the HPV thing I was talking about. Tonsil, when people usually complain, well, I feel that like there is something stuck on the side of my throat. That's the typical presentation of it. And have you looked in your throat? Well, yes, I saw my left tonsil is a little bit bigger. You know, any asymmetry in an adult human body better be checked out. In head and neck, if there is a unilateral process, it's supposed to be treated as cancer unless proven otherwise. You know, polyp in the nose on one side has to be treated as a cancer unless proven otherwise. So tonsil on one side is bigger, has to be treated as a cancer unless proven otherwise. So has to be investigated or approached as a cancer. So Well, usually pharyngeal cancer 3-4 times more common in men. Lymphomas usually present in the tonsil, but usually lymphoma present with both tonsils getting bigger. And it's extremely rare for adult to have tonsils growing. So usually we kind of catch the cases really quickly, and it's treated with chemo. But if it's unilateral process, it needs to be approached seriously. Again, don't let it slide. Don't try to take home remedies longer. You can do it, absolutely. But 3 weeks, magic number, 3 weeks. If it's longer than 3 weeks, it needs to be checked out. So laryngeal cancer. Somebody says, well, feels like most commonly. I was eating chicken, or I stopped by Popeyes or KFC, and there was a piece of bone and it got stuck. And since then, it was 2 or 3 months ago, I feel there is something. Chicken bone does not behave that way. Usually, most commonly, chicken bone scratches you, you have some discomfort for a few days and then goes away. If it's longer than 3 weeks, it needs to be checked out. Top picture, that's how our voice box is supposed to look. And these are vocal cords, that's how we speak. And on the sides right here, these are called piriform sinuses. These are really tricky locations. It's sort of like in between our throat and our voice box. These folds right here, called aryepiglottic folds. That's what divides our throat from our breathing throat, our swallowing throat and breathing throat. That's what prevents us from choking all the time, because our aryepiglottic folds, they collapse like that to protect our airway from passing juice or some food. Because right here, right behind our throat in this slit, this is our esophagus. That's our food pipe. That's where all the food goes. That's why when we swallow, all these structures right here and right here, as well as right here, there is an epiglottis. They collapse to protect our airway. So that's how our throat's supposed to look like. But if you look on the bottom right, you see these are vocal cords right here. This is a little bit different orientation. But look at this structure right here. So that's the cancer, and that's the cancer of so-called piriform sinus. In this case, it's a left piriform sinus. It's the area